Many decades ago, Robin McKenzie, a physiotherapist in New Zealand, figured out by trial and error with over 30,000 patients that most orthopedic disorders are disorders of movement or mechanics, and therefore they have a mechanical solution, which is in contrast to a solution that's pharmaceutical or anti-inflammatory based or procedural based, like surgery. And the latest addition to a series of how to treat your own orthopedic disorders or orthopedic mechanical derangements is treat your own hip. Now, one of the biggest problems with this is so much hip pain, hip symptoms are coming from the lumbar spine. Rosedale et al. Did a study called the XPOS study a few years ago, which looked at patients who had isolated extremity joint pain without contemporary spinal symptoms, and found that about 71% of people who presented to this cohort of people trained in mechanical diagnosis and therapy had hip pain that was resolved with moving the lumbar spine. Nevertheless, some hip pain is coming from the hip joint in contrast to the lumbar spine and in contrast to muscles or degenerative processes. So mechanical disorders of the hip, what I would call a mechanical hip derangement, are detailed in this book. And if you would like to self-assess and see if that's the problem causing your hip problem and then self-treat, this book can be invaluable. Also, Treat Your Own Back might be a good place to start, especially if you have spine symptoms at the same time or in the recent past. So when I find that there's a hip derangement, I've ruled out the lumbar spine. I might have ruled out that there's an SI joint problem manifesting as symptoms in the hip, and I've ruled out red flags, and I think we're on to something mechanical versus structural or inflammatory or degenerative. Then there are several movements of the hip that could be potentially the patient's directional preference. The most common of the different movements of the hip that I find are therapeutic are hip extension in loaded, which is in weight bearing, and hip internal rotation, also in weight bearing. What we tend to find is that the weight bearing joints of the body, the hip, knee, and ankle, and smaller joints of the feet, tend to respond more often to mechanical directional preference movements in weight bearing versus on the table, for example, in non-weight bearing. So I'll show you what hip extension in weight bearing looks like with some overpressure, and I'll show you what hip internal rotation in weight bearing looks like as well. So hip extension, if I'm talking about my right hip, then in half kneeling, you're going to extend that right hip, and you can apply some pressure through the proximal femur, through the buttock muscles, to get a little bit of overpressure. So that's often a move I will use to restore mobility and function to a painful hip joint. Internal rotation is a little bit more tricky. However, if we're talking about the right hip, the right foot will come out, which is rotating the hip in, and then the patient is just turning to the right. So it doesn't make too much intuitive sense, but by bringing the foot out, I'm internally rotating the hip, and by turning my trunk, I'm internally rotating the hip more. Now I ask patients to kind of feel where their limit is and not keep twisting past it, because I want the movement to be coming from the hip, similar to the pelvis, and not an aggressive twist on the low back or the mid back. And thirdly, sometimes we combine those movements whereby we put the hip in some internal rotation with the foot out, and I can block that foot with my foot or have the patient use a table or something sturdy to keep that foot out, which keeps the hip in internal rotation. But I can internally rotate the hip and then go into some extension. Now we can also look at external rotation or flexion, a number of different movements of the hip. But one hypothesis as to why we tend to find most hip derangements respond to these movements, and it's a hypothesis, is that it's the movement that we are in less. So most of our day we're spent in some hip flexion and a lot of hip external rotation if we cross our legs or just let our thigh kind of rotate out when we sit. So again, main points, a lot of hip pain, 71% at least, in this XPOS study, corroborated in some other studies that do note that hip pain can be referred from the lumbar spine. But a lot of hip pain is coming from the lumbar spine. So when I take my verbal history from a patient, I'm thinking about that and asking questions that pertain to that line of questioning. And if we do find that the pain is coming from the hip, then I'm curious if it's a mechanical hip derangement that responds to directional preference movement, if it's something from the musculature, if it's something structural. When I say musculature, I also mean tendinous, or degenerative, or something that's not musculoskeletal in nature.